Welcome back. In this video, we bring you 25 Harvard exam questions and answers. The topic is cardiovascular system. We have anatomy questions, physiology, embryology, pathology, and even clinical questions. So you will no doubt enjoy this video. To benefit, pause the video at each question. Try to think and to answer it yourself first. We encourage you to have a pen and a paper alongside with you. Please like and subscribe to my channel. Question 1. A 55-year-old man presents with an inferior wall myocardial infarction. Which coronary artery is most likely occluded? And what is its most consistent anatomical origin? Pause the video now. Here comes the answer. It is the right coronary artery. This artery originates from the right aortic sinus or the anterior sinus of Valsalva, which is a small pouch in the aorta. This artery travels in the groove between the right atrium and the right ventricle. This artery supplies the SA node in 60% of people. Always remember, the right coronary artery is equal to the right coronary, right ventricle, right sinus, and the SA node is a passenger on that train in most people. Question 2. During a dissection, you identify a vein that drains the posterior interventricular septum and empties into the coronary sinus. Name this vein. Pause the video now. Here comes the answer. It is the middle cardiac vein, also known as the posterior interventricular vein. You know, the middle cardiac vein runs with the posterior descending artery. It is the Berkeley of coronary drainage. Question 3. Which structure separates the right atrium from the left atrium during embryologic development and is clinically important for transeptal during catheter ablation? Pause the video now. And here comes the answer. It is the septum primum, which forms the floor of the fossa ovalis. The limbus of the fossa ovalis is the massecular rim derived from the septum secundum. So, during embryologic development, the septum primum separates the right atrium from the left atrium. And during a transeptal puncture, you pop through the septum primum, which is the thin membrane, not the thick limbus. Question 4. A patient with a left-sided pleural effusion is tapped at the fifth intercostal space. What is the risk of injury to the heart if the needle is too medial? You may now pause the video. Here comes the answer. If a needle is inserted too medially during a thoracentesis, the structure most at risk is the injury to the heart, specifically the right ventricle. Why? It's because the right ventricle is the most anterior chamber of the heart. It sits directly behind the sternum and the mediastinal pleura. If you tap too far medially, you hit the right ventricle. And the consequence? Tension, hemopericardium might happen. Question 5. Which papillary muscle is most commonly ruptured in acute inferior myocardial infarction? Pause the video now. Type your answer in the comment below. Let us see those correct answers. At the end of the video, I will share the correct answer. Let's see which papillary muscle is most commonly ruptured in acute inferior MI. Question 6. What is the embryologic origin of the coronary artery endothelial cells? You may now pause the video. Here comes the answer. The coronary artery endothelial cells come from proepicardium organ, specifically the epicardium-derived cells. These cells migrate over the heart and differentiate into coronary endothelial cells, smooth muscles, and also fibroblasts. Did you know? The heart's own blood supply doesn't come from the endocardium. It comes from the outside in, from the proepicardium, and not from the endocardium. Question 7. A neonate presents with cyanosis and a boot-shaped heart on chest X-ray. What is the most likely embryologic error? You may pause the video now. Type your answer in the comments below. The correct answer is cyanosis plus boot-shaped heart on chest X-ray points towards tetralogy of Fallot. Tetralogy of Fallot is caused by anterior displacement of the cornal septum, also known as the infundibula or outlet septum. The anterior displacement of the cornal septum leads to the right ventricular outflow tract obstruction, overriding of the aorta, leading to right ventricular hypertrophy and ventricular septal defect, because the cornal septum fails to properly align with the rest of the ventricular septum. So a large hole is left between the left and the right ventricles. So think cornal septum goes forward, the aorta goes over the hole, the baby goes blue, cyanosis. Question 8. The atrioventricular AV node develops from which primitive structure? You may pause the video. Here comes the answer. The AV node originates from the posterior wall of the sinus venosus near the AV canal, while the AC node comes from the right horn of the sinus venosus. So both nodes, the AC node and the AV node, come from the sinus venosus. AC node from the right horn, AV node from the posterior wall. So AC node stays up high and AV node migrates down. Question 9. What is the fate of the bulbus cordis after the looping stage? You may pause the video now, and here comes the answer. After the cardiac looping stage, the bulbus cordis is divided into 3 distinct segments. Proximal third forms the trabeculated, the rough part of the right ventricle. Mid portion, conus cordis, give rise to the outflow tracts of both ventricles, specifically the infundibulum, the conus arteriosus of the right ventricle and the aortic vestibule of the left ventricle. Then the distal segment, the truncus arteriosus, contributes to the formation of the proximal portions of the aorta and the pulmonary trunk. Question 10. A patient with aortic stenosis has a calculated valve area of 0.8 centimeters squared. Using the Gorlin formula, what is the primary hemodynamic consequence? You may pause the video at this point, and here comes the answer. A calculated aortic valve area of 0.8 centimeters squared indicates severe aortic stenosis. Severe aortic stenosis is typically defined as less than 1 centimeter squared. Now, the primary hemodynamic consequence is a significant systolic pressure gradient between the left ventricle and the aorta, leading to impaired forward cardiac output and compensatory left ventricular hypertrophy. The stress in the wall of aorta in aortic stenosis makes the heart thick. The Gorlin formula gives us the area, but the wall stress is what kills the patient. 11. During exercise, what happens to the arteriovenous oxygen difference? You may now pause the video, and here comes the answer. It increases. This is because working muscles extract more oxygen. So when you are exercising, your body, your heart pumps more blood. At the same time, during exercise, the body, the muscles get more oxygen from the blood. The arteriovenous oxygen difference is the hidden hero during exercise. Question 12 is about the Frank-Starling mechanism. What is it? And what parameter defines it? You may pause the video now, and here comes the answer. The Frank-Starling mechanism states that stroke volume increases with increased end diastolic volume up to a point, meaning the more the heart muscle walls are stretched by blood filling the ventricles, the more forcefully they contract. This allows the heart to automatically pump out the exact volume of blood that flows into it, maintaining a perfectly balanced circulation. The fundamental parameter that defines the Frank-Starling mechanism is the preload, which is technically measured as the end diastolic volume or the end diastolic pressure. Question 13. A patient has a heart rate of 50 beats per minute and a stroke volume of 100 ml. Their cardiac output is 5 liters per minute. What is their ejection fraction if the end diastolic volume is 150 ml? You may pause the video, get a pencil and a paper. Let's calculate together. Ejection fraction is equal to the stroke volume divided by the end diastolic volume times 100%. This patient has a stroke volume of 100 ml. His end diastolic volume is 150. So 100 divided by 150 times 100%. So we have 67% of the ejection fraction. So remember that ejection fraction is not the cardiac output. It is the pump efficiency. Our patient's heart rate is 50 beats per minute. That is bradycardia. So he is bradycardic, but compensates with big stroke volume. So the ejection fraction is normal. Question 14. What causes the dicrotic notch on the aortic pressure waveform? Please pause the video, and here comes the answer. The dicrotic notch is caused by the closure of the aortic valve at the end of ventricular systole. This momentarily changes the blood flow and produces a brief backward flow of blood toward the heart. So yes, the brief backflow of blood against the closed valve creates a small upward deflection. Whenever you see the dicrotic notch, think in your mind that the valve slams shut. And if there is no notch, that means that we're talking about aortic regurgitation. 15. What effect does atrial contraction, the atrial kick, have on ventricular filling in a normal heart? You may please pause the video now. In a normal heart, atrial contraction, the atrial kick, actively pushes blood into the ventricles at the very end of diastole, contributing the final 20% to 30% of total ventricular filling volume. But in steep ventricles, this contribution becomes critical. Now, in conditions like atrial fibrillation, the atrial kick or atrial contraction is not present, it is lost. Those patients' hearts feel the ventricle immediately, and that explains why some patients experience shortness of breath. Question 16. A 70-year-old hypertensive woman has a blood pressure of 170 over 110 mm mercury and a loud S4 gallop. What is the most likely underlying myocardial pathology? You may pause the video and please share your answer in the comments below. The most likely underlying myocardial pathology is the left ventricular hypertrophy, which results in decreased ventricular compliance. You know, the S4 gallop or the atrial gallop, it is an abnormal heart sound which is heard best at the apex with the bell of the state. It is the sound which is produced when the atria actively contract to force blood into a stiff, non-compliant ventricle. Question 17. What is the histologic hallmark of hypertrophic cardiomyopathy? You may pause the video now and share your answer in the comment section. The primary histologic hallmarks of hypertrophic cardiomyopathy involve a triad of these microscopic features, which are: number 1, myocyte disarray. This is a diagnostic feature. So here, the heart muscles, the myocytes, are arranged in a disorganized, chaotic pattern. Number 2 is the myocyte hypertrophy. Here, the heart muscle cells, the myocytes, are significantly enlarged. Number 3 is the the myocardial fibrosis, which is just an excessive buildup of collagen and scar tissue between the muscle cells, between the myocytes and around blood vessels. Question 18. A 45-year-old man dies suddenly while playing basketball. Autopsy shows a ruptured ascending aortic dissection. What are the microscopic changes in the aortic media? You may pause the video now and share the microscopic changes in the comment section. Here comes the answer. The microscopic changes in the aortic media for ascending aortic dissections typically reveal cystic medial degeneration. This involves loss of smooth muscle, fragmentation of elastic fibers, and accumulation of basophilic ground substance. You know, cystic medial degeneration is the weak spot in the aortic wall. Question 19. A biopsy of a cardiac tumor shows strap-like cells with cross striations. What is the most likely diagnosis? Would you pause the video and answer this question? The correct diagnosis is rhabdomyoma, which is a benign cardiac tumor, and it is often associated with the tuberous sclerosis complex. So when you see strap cells plus cross striations, think first rhabdomyoma. Question 20. What is the most common cause of infective endocarditis in intravenous drug users? Pause the video and share your answer in the comment section. The most common cause is Staphylococcus aureus, which affect the tricuspid valve. So IV drug users or the junkies, when they have endocarditis, think first about the Staph aureus, which affect the tricuspid valve in most cases. Question 21. A patient has a wide complex tachycardia at 180 beats per minute, no P waves, and irregular rhythm. What is the most likely diagnosis and the immediate treatment? Pause the video now. Try to answer this question first. Then here is the answer. The most likely diagnosis is atrial fibrillation, AFib. The immediate treatment, if unstable, synchronized cardioversion. But if stable, we do the rate control or rhythm control. So when a patient has a wide and irregular rhythm, think AFib with aberrancy first. And please don't give adenosine because it can cause ventricular fibrillation if there is pre-excitation. And follow the treatment guideline. Question 22. A patient with heart failure has a BNP of 1,200 pg per ml. Which type of heart failure is more likely? And what is the primary reason for BNP elevation? Pause the video and here comes the answer. So a patient with a BNP of 1,200 pg per ml is more likely to have heart failure with a reduced ejection fraction, HFrEF. The primary reason for this severe elevation in his BNP is because of the increase in ventricular wall stress, which is caused by volume or pressure overload. You know, the BNP is released from ventricular myocytes in response to increased wall tension. Question 23. A 65-year-old male with chest pain has ST elevation in leads 2, 3, and AVF. Which artery is likely occluded? And what is the immediate mortality risk? You may now pause the video and here comes the answer. ST segment elevation in leads 2, 3, and AVF indicates and inferior wall STEMI, ST segment myocardial infarction. Likely occluded artery in 80% of the cases, it is the right coronary artery. This is the main culprit. The remaining 20% are caused by the occlusion of the left circumflex artery. Immediate risk for mortality is about 2 to 9%. This comes because of bradycardia, hypotension, and right ventricular infarction. Question 24. What is the NIHA functional classification for a patient who is comfortable at rest but has symptoms with less than ordinary activity? NIHA means New York Heart Association. Your answer now. So a patient who is comfortable at rest but experiences symptoms like fatigue, shortness of breath, or palpitations with less than ordinary activity is classified as NIHA class number 3. In class 1, there is no limitation of physical activity, no symptoms at ordinary activity. Class 2, there is a slight limitation, comfortable at rest, but ordinary activity result in some symptoms. Class 3, that's where there is marked limitation. The patient at rest is comfortable, but less than the usual physical activity will bring about symptoms. Then class 4, there is severe limitation. The patient here might even have symptoms at rest. Question 25. A patient on warfarin has an INR of 6 with major bleeding like intracranial hemorrhage. What is the immediate reversal agent? Pause the video now. The answer? For a warfarin anticoagulated patient who has life-threatening major bleeding, such as an intracranial hemorrhage, the primary reversal agent is the 4-factor prothrombin complex concentrate, the PCC. We give this drug alongside with the IV vitamin K. This PCC, prothrombin complex concentrate, is the drug of choice because it rapidly and effectively replaces the vitamin K dependent clotting factors, which are factor 2, factor 7, 9, and factor 10. It helps normalize the INR within minutes. It's about 10 to 30 minutes. Also, it carries a lower volume overload risk than blood products. So question 5. Let's go back. The question was, which papillary muscle is most commonly ruptured in acute inferior myocardial infarction? The correct answer is the posterior medial papillary muscle of the mitral valve. Please check your answer and confirm that indeed it was the posterior medial papillary muscle. Did you enjoy? Has this video helped you? If so, subscribe to Dr. Exam Questions and Answers. Thanks for watching.